So, I'm going to speak about the topo-guided treatment in highly aberrated corneas. These are my financial interests. So, when you look at aberration, you are trying to look at both the quantity and the quality of vision, and you end up in different aberrations, which are related to old RK being done, a very poorly centered ablation, patient with regression, and also when you're looking at keratoconus. So, what are the challenges associated with handling them? Is your blurred vision, the challenges of glare halos, night vision challenges, eye strains, which comes with compensating for these aberrations, and all this have a huge impact on a low quality of life. So what we have is options of topo-guided treatment. We have an options in, we call it TREC, topo-guided removal of epithelium and reshaping it, and corneal remodeling and shaping. So when you look at topo-guided treatments now, we have, we call it TCATs. You have a platform from Alcons, we have a platform from Zeiss, and we have also a very strong platform from Schwinn. The Schwinn looks at two things. You look at an ocular wavefront, which is a total wavefront using their pyramis, which is their abrometer, and also the corneal wavefront, which looks at more regularizing the cornea. But challenges here is, when do we choose and what do we choose? Many times when you have only corneal related aberrations, the amount of ablation is huge because it assumes that everything is the cornea. There was only one lens in the eye. But when you have a cornea which has a total aberration, it neutralizes a lot of aberrations from the lens. Lens neutralizes aberration, so the amount of ablation on the cornea gets minimized. So it compensates for what is already happening, which is naturally happening in the eyes. So the ocular wavefront, if you have a good abrometer, in that way, the pyramidal wavefront abrometer of Pyramis from CSO is excellent. Even in the most aberrated eye, you're able to get a really repeatable and a decent aberrations. You're also able to change the aberrations. Some of those, when you have a high level of aberrations being treated, your ablation depth increases. So you can actually, machine itself knocks off the ones which are not important and just treats what are significant in your procedures. And you always look at the amount of coma, what axis is your coma, and it gives you in both in microns and diopters, which also has a huge impact because you know that this amount of coma will be disappeared or will reduce with this axis when you're treating these aberrations. So it's always very interesting with how softwares are trying to help us in understanding full aberration profile rather than just telling you this is what you treat, this is how the ablation profile is, and then finish. And these are a few examples when we have been able to treat. We have been doing it for the last 8.5 years now, and we have just published long-term results of this with very stable refraction and very, very small number of patients who needed a repeat cross-linking. But when you have a cornea which is thinner, and when you feel that the aberrations are, when you don't have enough tissue to do the topo-guided treatment, we designed a technique called a TREC, where you are able to do a small PTK over the corneal zone, the corneal cone. When you do a PTK on that, you can customize this, and this is how you do. You localize the cone, make an ablation profile, and this is a small PTK on the cone, and then you can knock it off, and then later you do a cross-linking. Again, we published this work in JRS, long-term results of this, and this has been quite amazing about how this can help in improving the quality of vision. And these are just a few cases which shows that just by this is more like a very customized cretin protocol. Cretin protocol by Kaimonis showed that you can do a PTK and it kind of improves the quality of vision. And this is a combination of how we did the both 1 year data of TREC and the topo-guided treatment. So what I'm going to talk now in the next few minutes is about using the ray tracing principle and how ray tracing algorithm is now coming into fore beyond our conventional abrometers and topo-guided treatments. The new abrometers, which uses the ray tracing, does the ray tracing from your epithelium because epithelium forms a very important refractive surface. the anterior and the posterior. The posterior ray tracing is very important because most of the aberrometers extrapolate the data or assume certain amount of change, which cannot be assumed, especially when you are doing irregular corneas. And the area of what we are working is with a company called IWIS. They have their own machine here. If you are interesting, they use a Precisio, which is their aberrometer, which is ray tracing aberrometer. They put a lot of efforts on the pupil size. They use 8 different pupil condition to get the right optimal size, and their optical zone is based on that ideal pupil size. And this is a ray tracing of your epithelium, ray tracing in terms of refractive map. This is the corneal ray tracing. And the zone, optical zone, is based on your pupil size, and then it uses a ray tracing map. It includes the epithelium and also looks at how the epithelium would heal post-op to after the particular surgery is done. So a customized transition zone, for example, the transition zone is not equal. It's customized transition zone according to your pupil and according to the area of how it works. And these are the ablation maps, and this is how, especially in a pellucid, these are the ablation map, what it does, and this is how epithelium now has become much more regular post-surgery. And there's a few images of outcomes, what we see in the right and left, and it's quite amazing how the next generation of these ray tracing are going to change the way we see our refractive patient. And you can see that how the keratoconus is now being able to, we can work on it like how you're doing a LASIK or a refractive procedures. So there are still challenges of flattening, altered accommodation, epithelial remodeling, and neuroadaptation. And these are all the challenges which we feel. The eye has been adapted to a certain level of accommodation. This is on the Osiris. This is how the accommodation happens, and we are able to measure these accommodations. And these challenges, if you're neuro-adapted to a certain level of accommodation, these things don't change much, and the patient's quality of vision may improve, but the refractive error may not really fully change. So that is something which we need to keep it in mind. So topo-guided laser vision has been a revolution and in an highly aberrated eyes, and they've been a big boon. And ray tracing technology, I think, would be the future of how topo-guided treatment will be done, with more AI-driven process and understanding of biomechanics, wound healing, and also when we look at the future of adaptive optics, where you can choose what aberration to treat, I think we might end up in highly customizing the irregular corneal ablation. Thank you.